ENT surgeon or ear specialist from St Vincent's here, and we've worked with Dr. Biggs for a long time, and he's been doing a presentation for Hearing Awareness Week for several years now, so we'd like to thank him for coming again.
Thanks, Vanessa. Can everybody hear me?
I should hear, but not real clear.
Okay. Is that any better?
That's a bit better.
A bit better. Okay. Thank you for coming along. Vanessa and the group from Hearing and Balance asked me to talk a little bit more on otosclerosis this year, which is an interesting condition, as well as some surgical solutions to hearing loss. As Vanessa said, I'm an otologist or ENT surgeon with a special interest in ear surgery at St Vincent's Hospital, and what I'm going to cover is things that we can do from a surgeon's perspective about correcting hearing loss, which is very exciting from my perspective, but not the answer to everything, unfortunately. So what I thought I'd cover today is a few topics. First of all, we'll just go through the basic structures of the ear. It's very hard to understand a bit about what we do unless you understand some basic structures of the ear. Then I'm going to cover what we call otosclerosis, this specific condition, and the surgery for it. And then we'll briefly just cover some other topics, including other surgical approaches to correct certain types of hearing loss, and briefly mention implantable hearing aids and cochlear implants. So the ear, which is what we're here to talk about, has some important structures, and it looks like quite a complex organ, and in fact this diagram is quite basic compared to all the very fine structures that are involved in it. But I thought I'd sort of try and simplify things for us. And so the first part to be aware of is the ear canal. Okay, the ear canal, the outer part's made of cartilage and the inner part's made of bone. Okay, so it's a little hole in our skull, and it's something that we shouldn't put anything smaller down than our elbow, so no cotton buds. Okay, the ear canal is not a straight structure. It actually slopes and has a slight angle to it, and it varies in shapes and sizes. So that's it, ear canal. So the eardrum, okay, or the tympanic membrane, is a sound conducting mechanism. This mechanism vibrates with sound waves to send signals through to the inner ear. And then we've got the little bones of hearing. So we've got three of them, and these are the smallest bones in the body. So we have the malleus, or the hammer bone, and this bone is actually partly incorporated in the eardrum. We have the incus, or also known as the anvil, which connects the malleus to the deeper bone, and the stapes bone, or the stirrup bone. It looks like a horse's stirrup. So these three bones, as I said, are the smallest bones in the body, and combined with the eardrum, they act as an amplifier mechanism. So sound comes in through your ear, and the eardrum and these three little bones of hearing amplify sound waves through to our... Oops, gone too far. Amplify sound waves through to our inner ear, which is also called the cochlea. Okay, and the inner ear is what turns sound waves into nerve impulses. So, and I noticed that David Ryugo, our professor from the Garvan, is going to talk a little bit about hearing and brain, and David, I'm not sure if David's going to cover a little bit about the inner ear, and it should be a fascinating presentation, and I recommend you have a listen to David, who's really a world leader in his field. So hearing, I'm still doing it, I apologise. So hearing loss, if you look at our basic structures of the ear, can be divided up into two forms of hearing loss. So we can have a problem of hearing loss where the sound is not getting from the outside world through to the inner ear, so it's lacking conduction through to the inner ear. So that may be a problem in our ear canal, it might be a problem in our eardrum, it might be a problem in our middle ear. Or we can have inner ear hearing loss. So a hearing loss related to the inner ear or the cochlea, and this is our common form of hearing loss in the community, which is age-related hearing loss. It is also noise-induced hearing loss. So this is loss of those little, you might have heard of things called hair cells, the little tiny cells in the inner ear that turn sound waves into nerve impulses. This is where you lose the function there. So that's an inner ear hearing loss. So moving on to otosclerosis, which is an interesting condition which I have a particular interest in. And this is a condition of the middle ear, so this causes what we call a conductive hearing loss. And this is it's a funny condition that affects the stirrup bone. And it actually involves new bone growth or new bone being deposited around the base of this stirrup bone. So basically what this condition does is it stops sound being transmitted through to the inner ear. It stiffens the whole system up, so we lose our conduction mechanism, or we lose our amplifier with this condition. As I said, it's a funny condition. We know it has a genetic basis. It affects about 1% of the community, and it can run through families quite strongly, or it can skip generations. We know that just because you carry the gene for otosclerosis doesn't mean you're going to get the condition, so we think there may be some trigger factors, and there's been suggestions that the measles virus may help trigger it. We don't know. We know that it's a little bit more common in females, and interestingly in females, if you've got this condition and you fall pregnant, it actually accelerates the condition. So females classically get an increased hearing loss during pregnancy with this condition. So it's an interesting condition. We don't fully understand it, but it's been around for a long time. And we really, when it comes to treatment of otosclerosis, so this problem of lack of sound getting through to our inner ear, or this loss of our amplifier mechanism, we've really got two choices. Well, the third choice being doing nothing. But if you've got a hearing loss from this condition, you can try and restore your amplifier mechanism with a hearing aid. A hearing aid is an amplifier. You can replace the amplifier mechanism with a hearing aid. If you turn the volume up well enough, you should be able to hear with a hearing aid. And that has some real advantages, and it's got some disadvantages. And the alternative to otosclerosis, which I want to talk about, is surgery. And this is an operation called a stapedectomy. Now, stapedectomy has been around since the 1960s. And this operation, actually what we do today is actually called a stapedectomy. You don't have to get too worried about the difference between the two. But essentially what we do in this condition is we replace the stirrup bone with a little tiny artificial piston. Because basically this bone, as I said before, has been frozen up, so it's not moving, it's not vibrating as it should, so it's not sending the sound waves through to the inner ear. So what we do is we actually remove it and we replace it with a little tiny artificial piston, and that will help re-establish that transmission of sound waves through to the inner ear. And that's the size of the piston. So as you can see, it's the smallest bone in the body. The size piston that we use is about 0.4 of a millimetre in diameter, and it's 4 millimetres long, so it's pretty small. And what we do here, certainly at St Vincent's, is we use a laser to remove that bone. We're lucky enough that we've got a KTP laser here. We're the only hospital in the state that actually has one of these lasers. And this helps us remove this bone. This is a very standard operation that I do a lot of, and it takes about an hour or so. We sometimes do it while patients are awake. We sometimes do it while patients are asleep, depending on the situation. And it's normally a simple overnight stay in hospital. I've got some little pictures here. Hope this doesn't put people off. But we've actually got a view of the inner ear. This is taken under the microscope. So this is a high-powered microscope. We're looking down an ear. We've actually lifted up the eardrum. And we've got one of the bones of hearing here and the stirrup bone there. And what we're actually doing is removing this stirrup bone here. And we've got a little video here. Just hopefully it will run. It's not going to run. Oh no. Oh well. Basically, I was going to show you a little video of this red thing here is our laser fibre, which is a 0.2 millimetre laser fibre. I was just going to show the the removal of that, and then the next one was going to show the placement of the piston. So I'm sorry, the video's not deciding to run today. No. I'll see if I can find it. So what we do is a laser stapedectomy, and this is something that we do, as I said, a lot of, and this helps correct this problem of otosclerosis. As I said, it's a pretty standard procedure, but it's also a very delicate procedure, so we have to be very careful in this procedure that we don't do any harm.
How do you find that out? Has someone spot that?
The diagnosis of otosclerosis is one based on clinical presentation, so the history of somebody's hearing loss, having a conductive hearing loss, as we said, and not having any other potential cause for the hearing loss. In other words, they haven't had trauma to their ear, they haven't had a big hole in their eardrum or something like that. But the actual diagnosis you can sometimes make on a CT scan, but most of the time we actually only make the diagnosis when we lift up the eardrum. We know about 90% of the cases when we actually lift up the eardrum, if we think they've got otosclerosis, 90% of people will. Yeah. But about 10% of people won't, and sometimes we have to deal with different things. So that's a little bit about otosclerosis. I don't want to get too much in detail about it, but it's an interesting condition, and it's one of the conditions from a surgeon's perspective is very satisfying, because we can take somebody who has a very significant hearing loss and we can do something about it. And out of all of our operations for hearing loss, it is one of the most successful operations that we can get. So if you've got otosclerosis and we get a good result with surgery, people are very happy because they don't need a hearing aid, they've got hearing 24 hours a day. It really is a very nice, very satisfying operation. But as I said, it's a very delicate operation. It does carry risks, and if things go wrong, it's very unpleasant. So,
Can I just ask if the technique has changed over the last 20 years?
It's changed over the last 30 or 40 years. That
the way
first,
it's done.
yeah, the way it is done. When it was originally done, they used to take the entire stirrup bone out, which is more likely to damage the inner ear. Nowadays, we just drill and laser a little hole in the base of that stirrup bone and put that piston through that hole. So we're more likely to protect the inner ear and not do any harm to it. So yes, the technique's definitely much more refined than it used to be, and the success rate's better, and the complications of surgery are much lower. So that's a little bit about otosclerosis. Any questions on otosclerosis?
What is the success rate?
The success rate's about 92%, depending on who you ask, but it's about that.
Can the surgery be repeated in the present?
Yes, but the risks increase and the success rate decreases. So it's one of those operations you want to get it right the first time. You can revise it, but there are significant risks with revision surgery, and it's because the nature of the surgery involves opening the inner ear. You've got to be very careful that you don't do any harm. So there are certain circumstances where if the result has been unsuccessful, we say, look, reoperating this way is not going to fix the problem or runs too many risks. We've got an alternative option to do.
The diagnosis sounds simple. I've had a hearing loss for about 15, 20 years. I've never heard of it.
No, as I said, it only represents a small percentage of the community, and you have to have a conductive hearing loss. Now that most hearing losses, the commonest hearing loss in the community is a sensory neural or inner ear hearing loss. And it's very characteristic on a hearing test, and when we examine somebody, we can determine pretty well straight away whether or not their hearing loss is conductive, so a problem of the middle ear or a problem of the inner ear. And if nobody's ever discussed with you that you've got a conductive hearing loss, then the likelihood is you've got an inner ear hearing loss, and this is a bit of a moot point.
Would you operate on both ears?
You have to separate the operations by a minimum of 6 months, and you have to have successful surgery on one side before you would touch the other side. So you never do, in ear surgery, apart from putting in little grommets, we never do two sides at once.
After cochlear implant operation, do the patient recovers the hearing according to the age? I mean, it's delays if it's an older person.
Well, we'll get to that a little bit, but age can have an impact on success of cochlear implantation, but not particularly on this operation.
And the different language that brought up with?
Not so much, I'm not aware. Vanessa or Patrice might be more, one of our audiologists who do our rehabilitation for cochlear implantation might give you a better answer on that, but not that I'm aware of.
I come to that because doctors say that the people with age go back naturally to their motherland and mother's tongue, and therefore forget the current language that use.
If your mental faculties aren't that sharp, you're not going to be so successful with an implant. That's as a general rule.
Yeah.
So we've just talked a little bit about one of the causes of conductive hearing loss, which was otosclerosis, and I'll just mention a few other causes of correction of conductive hearing loss, or other surgical and surgical
Balancing That's